Assalamu alaikum wa rahmatullahi wa barakatuh. This lecture is the third lecture of disorders of bone. We will talk today about Paget's disease of bone, central giant cell granuloma, tori, and dense bone islands. Paget disease of bone, also known as osteitis deformans. It is a form of osteodystrophy, meaning there is disorganization of the bone. So the disorganization is in bone formation and bone resorption. They do not follow the normal remodeling process when the body responds by resorption or deposition according to the demand. So here there is no response to demand. It is unrelated to the functional requirements. That's why we will end up having osteodystrophy and disorganized bone structure. It is unrelated to the functional requirements, and here I summarized for you most of the features of the phases of Paget's disease of bone. Now, Paget disease of bone is having three phases. One, early lytic phase, or phase number 1. Phase number 2, which is the intermediate or mixed phase. And phase number 3 is the final, or the late phase, or the end phase, end stage, call it whatever you want. So at least you want to have three phases: early, intermediate, and final. In the early phase, what is going on is that the bone is actively resorbed and removed by osteoclasts. So the osteoclasts are removing the bone, and the resorbed areas are filled by fibrovascular tissue. So now you can imagine that the bone is not strong. It is having empty spaces resorbed by osteoclasts, and they are replaced by fibrovascular. Now, vascular component of the tissue is by itself a big issue in this phase, because this is a highly vascular marrow space or tissue, highly vascular tissue. And in this highly vascular marrow or marrow spaces or tissue, you will find arterial-venous communications. If you remember the AV malformation, a developmental change where we have a thick-walled artery communicating directly with a vein. It is not passing through the normal histologic appearance of thick-walled artery into arteriole, into capillary, and then we have venule and then vein. No, it goes from artery to vein. And in this condition, or in these circumstances, if you will have a surgery or surgical procedure done, you will have excessive bleeding. So, resorption of bone, highly vascular marrow, and radiographically, what are you expecting to find? You'll find sharply defined, there's a typo mistake here, sharply defined radiolucent areas. Okay, clinically, what do we have? The bone is softened, it is soft, easily fractured, and it is distorted. Now, the overall size is increased. Why it is increased if we don't have bone deposition? Maybe because of the arteriovenous communication, excessive fibrovascular tissue formation, but the result is we have soft bone. Complications in this phase, what do we have? We will have bleeding, hemorrhage if extraction was performed, and we will have occlusal changes because of the change of the size of the bone. Here I'm talking about the jaws in general. Okay, let's go to the second phase. We will go in the same way of categorizing the changes or findings in the second phase. In the second phase, we will have osteolysis, meaning osteoclastic activity, and osteoblastic activity. But the osteoblastic activity will result in formation of woven bone. Do you remember when I compared to you woven bone with the lamellar mature bone? We said woven bone is having matrix of bone that is not fully mineralized, it is not well organized, and it is weak. And I told you, please imagine that woven bone is like woven bone to mature bone is like granulation tissue to mature fibrous tissue. Okay? Now we have coarse trabeculae of bone, we still have highly vascular marrow, we still have arteriovenous malformation. So both of the first and the second phases share highly vascular marrow and arteriovenous malformation. So you still have the complication of bleeding, hemorrhage if extraction was performed, and you still have the occlusal disturbances, and you still have that the bone is soft and distorted, and the overall size is increased. However, radiographically, okay, we will start finding radiodense areas gradually appearing in these radiolucent areas, and they appear like in a patchy osteosclerosis. What do we mean by patchy? It's like ill-defined radio-opaque areas. Ill-defined, like a patch which is ill-defined, giving you the cotton wool appearance. زي القطن اللي منفوش كيف بيكون شكله irregular و ill-defined margins. نفس الفكرة بتكون بالسكند فيز لأنه صار عندي mixed radiolucent و radio-opaque areas together, mixed osteoclastic activity مع osteoblastic activity. Let's go to the final stage, and in this final phase, what will happen is that this woven bone will be remodeled into lamellar bone, يعني بده يصير mature bone and will mineralized bone. But because we have increased remodeling, يعني إيش يعني increased remodeling؟ يعني we will have osteoclast, osteoblast, osteoclast, osteoblast, bone resorption, bone deposition. There is reverse in the activities going on in the bone, and these reverses occur in short, relatively يعني short period of time. But these numerous reverses in activity between osteoclast to osteoblast will result in numerous reversal line. إيش يعني reversal line? It is the line demarcating the reverse in the activity between osteoclast and osteoblast. In this line, there will be, it will have a different color compared to the surrounding bone. Usually it is slightly blue on the H and E stain sections, because the activity here or the mineralization of bone is reversed. راح يعطينا المosaic pattern and even histologically طبعا. Okay, now in the final stage, when we have mature lamellar bone, we will have dense bone. But as we said in osteopetrosis, although the bone is dense, we have more bony mass, but the bone is weak and it is more prone to fracture. It is dense and avascular. So the complications will change now. The complications will be fracture of the jaw during extraction and bone infection if bacteria or organisms get access into the underlying bone now or in the jaw bones. Why they are more prone to infection? As we said, in osteomyelitis, the people who do not have good blood supply to the area, they will not have good immune response to the infection. So they will end up with necrosis and osteomyelitis or sequestrum formation. So here we will have infections and bone fracture, of course, in addition to complications of the enlargement and size changes of the bone. Radiographically, now we will have radiodense sclerosis. And if we look specifically at the skull radiograph, you will see that the outer table of the skull is thickened. So you will not have the appearance between the table, the distinction between the outer cortical table of the skull with the inner layer of the skull in terms of bone radiodensity, so you will have the same density. We will explain it more when we pass by the radiograph. For the dental changes in the radiographic findings, we will have loss of the lamina dura. You know why? Because lamina dura is compact bone, it is radio-opaque. And the cancellous bone, or the bone where we have marrow spaces, is now dense. It is more radio-opaque. So there will be no contrast between the lamina dura and the surrounding dense bone. Or maybe if the lamina dura is involved in the osteoclastic activity and it is gone, it is eaten away. So maybe it will, after the remodeling, there will be no distinction. Okay, we will have, in the latest stage, we will have hypercementosis and ankylosis and loss of the lamina dura. This is another cause actually here because of the hypercementosis and ankylosis. So the cementum bone, the lamina dura is lost already. There's no distinction. Okay, now we will discuss again. First, we will continue a little bit about the investigations, complications, treatment of Paget disease, and then we will revise what we have summarized here in this table. Okay, the Paget disease can involve a single bone or limited number of bones, but the commonest bones to be involved are the weight-bearing areas, which are starting from the sacrum, going up to the lumbar, thoracic, and then the cervical vertebrae. These are the weight-bearing areas. And next, they will be followed by the skull and the femur. And also, if we are talking about the jaws, the maxilla is more involved than the mandible. What causes this dystrophy? Why do we have Paget disease? It is not known. Why the osteoclast abnormally function in this disease, also we don't know. Maybe it is due to certain viral infections, or maybe it is familial. So if there is certain genetics determinants for this disease. So these two main factors, but we are not sure exactly what is the cause. Now, most of the cases, they show mild distortion or they are incidentally discovered on radiographs. So you don't expect most of the patients with Paget disease of bone to present with the features we talked about. Most of them, they have subclinical disease. But bone pain is a complaint for those patients. Okay. Now, let's summarize here specific sites involvement complications. The skull, we will have compression on the sensory and motor nerves, and according to the area of compression, the resultant clinical features will appear. If the maxilla is involved, we will have many clinical changes. We will have enlarged alveolar ridges. They are thickened and widened, so the palate is flattened. We will have facial deformity. Imagine that the maxilla and the alveolar ridges are expanding. So for sure we will have facial deformity in those patients. Lip incompetence, because the alveolar bridges also are enlarged, expanded. The lip will also be apart, the upper lip from the lower lip. Those patients who are wearing dentures, they will find difficulty because of the changes of the alveolar ridges. Occlusion, if we have teeth, the teeth will be spaced, they will be retroclined, and the occlusion will change. In the osteolytic phase, when the osteoclasts are active, there will be root resorption. And in stage number 3, there will be hypercementosis and ankylosis. Okay, there will be hemorrhage active phase or phases, meaning phase number 1 and 2. The complication is the chance of having hemorrhage. And in late phases, extraction will show post-extraction bone infection, hypercementosis, ankylosis, fracture of the jaws, all of these complications. Here, I'm just telling you again to go back and check the summary table I prepared in the second slide, where you will find the radiographic, histopathologic, and the complications per phase. For the investigations of patients of Paget disease of bone, we need to have 2 tests. One will be for serum bone alkaline phosphatase, which will be elevated, while the serum calcium and phosphate are normal. So these are important findings for the diagnosis. How about treatment? There are medications to be used, like the bisphosphonates. Bisphosphonates is one, we talked about it and its role in the osteosclerosis of the jaws and the way they function by inhibiting the osteoclast, and sometimes by affecting angiogenesis. So it is needed for Paget disease, and it helps in improving the clinical course of the disease. However, there is risk of osteonecrosis, as we discussed. Calcitonin can be used. It inactivates the osteoclast. Calcium and vitamin D supplements can be also used. Complications of Paget disease of bone, other than the clinical features we discussed now, and other than compression on the nerves of the skull, the osteosarcoma has higher chance to occur in Paget disease of bone. Maybe because of the high activity, increased activity of the osteoblast and osteoclast, which will increase the chance of neoplastic proliferation, especially in patients with widespread disease. These are illustrations and examples on the 3 phases of the disease. Here you see the osteoclast eating the bone and forming rounded, resorbed areas that are filled by fibrovascular tissue. And then in this second phase, you will find the fibrovascular tissue is still there, but bone deposition and the new bone formation started to occur. For example, in this lacunae, look here, this is an osteoclast and it was resorbing this area. In the second phase, osteoblast started working in the same region. So here, this is a reversal line. The activity reversed from resorption to deposition. So we will have a mark where this activity was reversed. And these activities will go on side by side. So we will have numerous reversal lines. At the end stage, or the third phase, we will have multiple reversal lines, multiple mosaic pattern, and very limited areas of bone marrow. And the vascularity like this, it is not seen here anymore. This is reflected in this diagram also. Here we will have radiolucent areas or resorbed areas, and then we will have mixed yellow and red areas together, and then we'll go back to mainly yellow areas or bone formation. And the yellow is the remodeled woven bone. This is the H&E stain sections of Paget disease of bone. In this phase, you will find marrow spaces, but osteoclast is here. It is lying in a lacunae. Slightly shrinkage happened to this osteoclast during processing of the section, some retraction. This is an osteoclast, osteoclast, osteoclast. So resorption process is active. In this phase, I can say it is the mixed phase or the second phase because I have a lot of marrow spaces, maybe vascular spaces, and I have bone formation, but it is still not fully sclerotic. Even this phase, I cannot say this is the first phase. So you can say these illustrations are for the first 2 phases. While the third phase here, it is easily distinguished from the first 2 phases. You will see a lot of reversal line of activity, a lot of bone tissue formed, and very minimal marrow spaces. Deformed maxilla in this patient. Lips relation changed, prominence of the alveolar ridge. And if you look at the skull, you will have thickened skull, and in some cases it will induce pressure on the sensory and motor nerves, and as a result, the clinical features might vary. The deformed bone, we said it will be changed and deformed. That's why it's called deformance. Osteitis deformance. So you will have the bones deformed, the femur is bowed, it's like arc-shaped, as you see here. In special investigations, the activity of Paget disease is reflected here in the skull, in the scapula, in the vertebra, in the femur. And this is a deformed bone. In the osteosclerotic phase, you cannot even find that cotton wool appearance we talked about. The bones are completely dense and sclerotic. In some patients, the skull will be extensively deformed. Bowing of the bones. In this patient here, he was mainly affected by Paget disease of bone mainly affected his skull. So there was extensive thickening of the skull and compression on the nerves. So he was presented with long headache, slowly progressive hearing loss, and difficulty finding hats because of the enlargement of the skull in some areas. Look how the skull is deformed. For sure, this patient will be able to find hats. Why hats are an issue here? Because this disease is more common in the UK, and the tradition in UK is that they wear the hats. Okay, here the alveolar ridges are again malformed, enlarged, the occlusion is disturbed. In this case here, you will see that I don't see a lamina dura, I see hypercementosis and fusion between the cementum and the bone without having lamina dura. And you know the complications of this. Here, distortion of the occlusion and the shape of the skull. Look at these patches here, white patch, another white, and a third one, fourth, fifth, sixth. A lot of white patches mixed with radiolucent areas. So I would go more with the second stage of the disease in this picture. How about this phase? I will go also with the mixed because I see this osteoclast, which is multi-nucleated, 1, 2, 3, 4, and some maybe more here. Okay, and I see these osteoblasts rimming the bone. So there is resorption and deposition at the same time. At the same time, we still see vascular spaces and fibrovascular marrow. So this is the mixed phase, most likely. Look at the mosaic lines, crisscrossing lines. They are known as crisscrossing also in some textbooks, and they are scallop. Okay, reversal lines. What is reversal line? We said it indicates the junction of the reverse between osteoclastic resorption and osteoblastic deposition. Mosaic pattern of lamellar bone in Paget's disease of bone. Okay, now the second disease, we finished with the Paget disease of bone. We'll talk about central giant cell granuloma. Remember the peripheral giant cell granuloma, and you remember that it has multinucleated giant cells, and remember that we said there it is called peripheral because we have a central counterpart, peripheral occurring in the gingiva or soft tissue and the central occurring in the bone. We said peripheral occurs only in the tooth-bearing areas because it is most likely due to the multinucleated giant cells are most likely related to teeth in that in etiology or in origin. Let's talk now about the central giant cell granuloma, and I want you to recognize, it's very important to recognize that there are two types of central giant cell granuloma. These two types are different. Histologically, they are the same, but they are different in their clinical course, in their treatment, and in their radiographic features. But microscopically, I will see the same finding, multinucleated giant cells in fibrovascular stroma. It is the same histopathology. Look at this radiograph, and you can say we have multilocular radiolucent lesion expanding the mandible, both on the lingual and the buccal aspects, and maybe the cortex is perforated. I cannot tell from here, the buccal cortex. So for sure, this is aggressive central giant cell granuloma. Okay, it needs aggressive treatment. It has poorer prognosis in terms of recurrence, and it needs different approach. A radiolucent lesion in this area here, it is well defined. And here you need to think about other differential diagnoses. So in this case, we have well-defined radiolucent area with thinning, expansion, and as we said, here you have this well-defined radiolucent region. Look at the expanded inferior margin or inferior border of the mandible. The teeth can be displaced if they are involved. They can get resorbed according to the aggressiveness of the lesion. This is a multilocular radiolucent lesion involving the mandible or affecting the mandible. It is poorly demarcated. It is expanding the mandible lingually and buccally. So you need to think or include in your differential diagnosis list central giant cell granuloma, because it can be a small radiolucent well demarcated lesion like a cyst, and it can be resembling or similar to ameloblastoma. Okay, so in this case, I will include ameloblastoma in my differential diagnosis. Central giant cell granuloma, I can include aneurysmal bone cyst, I can include central hemangioma. OKC, maybe it will be on my list priority because it is expanding mandibular and buccal, and OKC rarely expand these two directions. It's usually anterior-posterior growth. So keep in mind central giant cell granuloma can be aggressive. Microscopic features, you will see multinucleated giant cells in fibrovascular background. Some of these RBCs will be visited, and we can see some hemosiderin. It looks like hyperparathyroidism or brown tumor of hyperparathyroidism. So whenever we multiple central giant cell granuloma, or even a single central giant cell granuloma, or even peripheral giant cell granuloma, we have to consider hyperparathyroidism and ask the clinician to check for the parathormone level in the blood and completely exclude it. We can also identify some trabeculae of bone mixed with the this stroma, which is the fibrocollagenous vascular or the fibrovascular stroma mixed with the multinucleated giant cells. These are areas of hemorrhage. Okay, why we have this multinucleated giant cell lesion inside the bone? If you remember, we talked in last semester about the trauma hemorrhage theory. And we said that a trauma to the mandible, for example, will induce bleeding. Bleeding will form a clot. Clot will heal. It will heal with granulation tissue, which will be remodeled into bone. This is the trauma and healing process, the normal one. But in the trauma hemorrhage or trauma hemorrhage theory is that sometimes the hemorrhage will occur in excessive amounts so that it will not form the clot, and it will not allow for the normal healing. This normal healing or abnormal healing can end up with this giant cell lesion. So sometimes they say it is reaction to some form of hemodynamic disturbance in bone marrow due to trauma and hemorrhage, which is a frustrated repair, meaning that this repair is abnormal, as we just explained. Treatment will be inoculation and curettage for most of the cases. However, those extensive cases that we explained and discussed, they will need different type of therapy for these aggressive courses. Therapy, I don't mean medications in this case, I mean surgical or even medications, because they found that sometimes they can give intralesional steroid injections, and they can end up with reducing the size of the lesions. Also, they talked about calcitonin and bisphosphonates that might help in reducing the extensive size of the aggressive central giant cell granulomas. So treatment is usually surgical, but in some cases they will need medical. Okay. A differential diagnosis for a giant cell lesion, microscopically identified. okay, will include giant cell epulis if it is peripheral, central giant cell granuloma, hyperparathyroidism, cherubism, and aneurysmal bone cyst. All of these will have multinucleated giant cells and fibrovascular trauma. The last part, or the part before the last in this lecture, is exostoses, and we talked about them in details in the developmental changes. They are outgrowth, they are developmental, but they can also be responding to stimulus. And if you remember, we talked about bruxism, and we said clenching of teeth might enhance the development of the maxillary torus and might increase its size. In specific locations, tori will take specific names, like this is the torus palatinus, torus mandibularis. We said that torus mandibularis might be superimposed in the radiographs over the roots of the teeth, so you need to pay attention. We discussed all of this in the developmental changes. You can just read it and you will remember all the details, inshallah. Here in this buccal exostoses, some patients will come asking about these exophytic bony masses on the buccal aspect of their teeth. This is also a type of exostoses, as again, they might be developmental in etiology, or the patient might be having certain habits. Their treatment is just surgical correction for aesthetic reason. And the last point is about dense bone island. It is bone scar. It's also called bone scar. Why we have occasionally dense bone island like this, sclerotic island within the bone, within the mandible, discovered incidentally on radiographs. It is symptomless, occurring premolar in the premolar and molar region, and they don't have any significance. They enter in the differential diagnosis of condensing osteitis also sometimes. Or let us say focal sclerotic osteomyelitis. Or just ignore what I said at the end of the differential diagnosis. I don't want you to. Well-defined, well-demarcated sclerotic area, not surrounded by radiolucent space. This is very important. Surrounded by radiolucent space. May be separated or associated with the root apex, and there is no clinical significance except that you want to distinguish them from the sclerotic masses like the condensing osteitis arising from periapical inflammation or periapical cemental dysplasia, so they will enter your differential. Okay, now let me just, before I end, to go back to the central giant cell granuloma and specify the most common location, which is the area between the mandibular premolars. But let me go back and find the location. So mandible more than the maxilla, and it is mostly in the anterior parts of the jaws, meaning anterior to the mandibular premolars. Okay, by this we arrive at the end of this lecture. Hope everything is clear. Please email me or let me know if you have any concerns. Thank you.